share my research on the perceptions of health misinformation on social media during a public health crisis with you this morning. First, I need to give you a little background on how this topic came up for me. As you may recall, I'm a certified physician assistant working in acute care surgery at Michigan Medicine Hospital. I am also certified in emergency medicine and have over 20 years combined experience as a practicing PA. Now back to the story on my research interests. Please keep in mind my intent is to give you my personal connection to this topic and hopefully not to stir up any PTSD in anyone. So last March, as the world was watching the beginning of what would become the COVID-19 pandemic, here in Michigan we were witnessing the first surge of the virus hitting our state. The chart on the left shows COVID infections and death rates in Michigan as of April 3rd, 2020. You can see, comparing to the Michigan population map on the right, the virus is primarily hitting in the more densely populated areas of our state, which will be important information later on. At the beginning of the pandemic surge, to prepare for an unknown influx of COVID patients, U of M Hospital canceled elective surgeries and procedures and sent non-essential workers home until further notice. A few days later, I received a call from the hospital letting me know that I was going to be deployed within the next 24 hours to work in a COVID ICU. My deployment would be for at least 4 weeks, and even though I live less than 3 miles from the hospital, they also told me that I was not going home during this time and they would be putting providers up in university housing or nearby hotels. We simply did not know enough about this pathogen at that time. So at 5 a.m. the next morning, I awoke to my pager and phone going off asking me where I was. Well, apparently one of those so-called non-essential workers was essential after all to communicating important team meeting information. While monitoring patients in the ICU, I had access to online resources that connected ICU, infectious disease, and critical care doctors from all over the world. The resources included information on how to care for these very sick patients. These documents culminated in algorithms like those shown here that were then shared all over the world. You could literally watch the comments coming into the shared Google document in real time, just evolving in front of your eyes. It was truly fascinating and scary at the same time. As this barrage of medical information sharing was going on inside the hospital, there was a whirlwind of information bombarding the news channels and social media outside the hospital that was changing rapidly by the minute. Memes and posts like the ones shown here were all over social media. Oh, and let's not forget about the rhetoric coming from the government regarding the pandemic about the precautionary measures needed to stay safe. The arguments back and forth from the government sources alone were a huge source of confusion to the general public, to say the least. That's when it hit me. If I, as a PA with over 20 years of experience, could hardly keep up with all the information going around regarding the COVID-19 pandemic, just how was the general public making sense of all of this information, and specifically, how were individuals with low health literacy understanding all the information out there and making decisions regarding their own health choices to stay safe? We know that greater than 30% of consumers seek health information from online sources, including sources such as Facebook, Twitter, and other social media. So just what is health literacy? Well, it's basically the ability to find, understand, and to use health information to function within the healthcare system in order to take care of oneself and others. E-health literacy is similar, but applies to health information found in electronic sources. So why does this matter? Well, because around 50% of the U.S. population holds a basic or below basic level of health literacy, and those numbers have not improved much over the years. I do feel that there's a strong correlation to race and health literacy contributing to these poor health outcomes. This is where intersectionality plays a part in my research. We think about intersectionality as how certain parts of your identity increase your access to good things or can increase your exposure to the bad things in life, like COVID illness. We listened to Dolores Brunel's talk on intersectionality within Lat Crit and feminist issues as one example of intersectionality. And our reading on Black feminist intersectionality from Kim Crenshaw was another example. People are often disadvantaged by multiple sources of oppression, such as racism, sexism, classism, ageism, location, and education that intersect and overlap to create disadvantages for some groups over others, like African Americans, Latinos, and Indigenous people who have experienced a high incidence of COVID-19 illnesses. For lower socioeconomic status urban populations, there are so many barriers due to race and class that limit access to care, contributing to poor health outcomes in these marginalized populations. If we take a moment to look specifically at the African American population in Michigan alone, we can see that the poverty and infected persons areas are fairly similar and centered in the southeast Michigan-Detroit area, which is one of the largest Black populations in the country. We also know African Americans have a higher rate of underlying diseases such as hypertension, heart disease, and diabetes, which predispose these populations to a higher rate of complications from COVID-19. This population is also more likely to work in essential jobs like being bus drivers, custodial staff, grocery workers, etc., that put them in close contact with others, making social distancing more difficult. Lack of consistent information from the government leaders causing distrust in the government, science, and factual critical information can also affect people's health decisions. And finally, housing disparities leaving people to live in close quarters to others again leads to the inability of social distancing themselves, causing an increased risk of getting sick. It all matters, and it all makes a difference in health outcomes. So this is where I could use your input. What else am I missing in regards to the intersectionality of race and health literacy? And do you see any value of pursuing storytelling within focus group research in underserved communities to better understand the implications of health misinformation, health literacy, and health outcomes in relation to the COVID-19 pandemic? Thank you for listening.